Good evening,
Yes.
everyone. I'll be presenting on interesting cases of limb ischemia in patients with COVID-19 and the role of mechanical thrombectomy. So, this is the first case, a 62-year-old lady who came with COVID pneumonia and severe ARDS. She was a diabetic and hypertensive. She was on a high peak non-invasive ventilation to begin with, otherwise stable. But after 10 days, she was noted to have pain in the right lower limb, and an arterial line was placed in the right femoral artery, following which she was on thromboprophylactic dose of Clexane. The line was removed and they increased the intensity of anticoagulation, despite which there was worsening of pain. The patient developed a foot drop, at which time a Doppler was done, which showed no flow in the femoral and popliteal segments, and a diagnosis of arterial thrombosis, like acute limb ischemia, was confirmed. So essentially, why did she develop arterial thrombosis, and how do I manage now? How to prevent it in future? So the worry here is this has happened despite the patient being on anticoagulation. At that stage, the patient was too sick to be shifted for a CT. Hence, the extent of thrombus was not sure, and she was considered prohibitively high risk for general anesthesia in view of severe ARDS. And the initial team was very against intubating this patient, and she was already on anticoagulation and considered too risky for spinal anesthesia. So we did consider an option of catheter-guided procedure, a diagnostic followed by a therapeutic intervention. So as you can see, this is a selective angiogram from the right common iliac artery, which shows an extensive thrombus in the proximal iliac extending into the femoral artery, following by another segment of thrombus in the femoral, followed by a complete occlusion in the popliteal segment. So the panel on the right, I show the pictures showing proximal external iliac artery thrombus, followed by an SFA thrombus, another segment of SMA thrombus, and occlusion at the popliteal level. So this is an extensive thrombosis, which is definitely not explained by the mere presence of the arterial line, despite patient being on anticoagulation. So we started off with a catheter-mediated thrombolysis. We put in a JR catheter with multiple site holes, and we've put an infusion of tenecteplase at 1 mg per hour. And the next day, as we saw, to our surprise, there's a significant clearance of the thrombus. But as you can see, there is occlusion of the profunda femoris with some thrombus in the proximal SFA, and again, infrapopliteally, it was completely occluded. So at that stage, we took up this penumbra mechanical thrombectomy. So now what is penumbra? It comes as three. There is one catheter, there is a separator, and a penumbra engine. So how is penumbra suction different from a routine thrombosuction with a syringe? As you can see the panel on the right, the suction pressure is uniform throughout the suction time, as against a syringe where the suction pressure falls drastically over the first 10 seconds. So this is the advantage of having a penumbra suction. So we took our penumbra catheter into the profunda, following which there was a significant clearance of thrombus and the flow was established in the profunda. Following which we went into the infrapopliteal region. As you can see, the one on the right, the penumbra catheter nicely tracking all the way into the infrapopliteal vessels. And this is the final angiogram for the day. We had the flow in the profunda. There was some vasospasm, but we could achieve a 2-vessel runoff in the infrapopliteal segment. Of course, there was a lot of thrombus. So post-op, we continued heparin infusion, targeting an APTT of 50 to 70 seconds, and we gave mannitol and steroids to prevent hyperperfusion edema. She required 2 units of blood transfusion to match the blood loss due to the procedure. But 48 hours later, this was the arterial Doppler. We did it at the bedside. As you can see on the both in the dorsalis pedis as well as the posterior tibial artery, there was extremely brisk flow, and the limb was warm, and the pain had also significantly reduced. Subsequently, the patient had the continuation of severe ARDS, and during the hospital stay, she developed enterococcal sepsis and she succumbed to her illness 13 days after the procedure because of multi-system involvement. This was the second case of a 43-year-old gentleman who had come in. Main presentation was pain for 4 days. His CT angiogram showed left lower limb arterial thrombosis, and a CT thorax at that stage was suggestive of Corad's 5, so he was referred away from his treating hospital. In fact, he was initially advised a below knee amputation, but because of COVID suspicion, nobody had admitted him. So he came over to us. His PCR was positive and he was only on like 4 liters of oxygen at presentation. His initial angiogram, however, showed bilateral external iliac artery thrombus and left infrapopliteal occlusion, complete occlusion with a limb ischemia. So we straight away went with a penumbra catheter thrombectomy in this guy without doing a catheter-guided thrombolysis, because this is a very fresh thrombus. His symptoms were only for 4 days, and the initial presentation itself was a limb ischemia in an otherwise healthy young gentleman. So this is a very useful adjunct to an intervention, something called a wire test. Basically, to see how mature the thrombus is. If your wire passes through the thrombus without any resistance, it means the thrombus can be easily amenable for mechanical thrombosuction. So because the wire went in very easily past the infrapopliteal vessels, we felt that it should be easily aspirated. So this is the final angiogram in the SFA and the infrapopliteal. As you can see, there was some slow flow because of the diffuse thrombus, but a good two-vessel runoff was achieved. There was some thrombus in the distal segment of the posterior tibial artery, because of which, and also there was bilateral external iliac thrombus, which was pretty big for the to actually engage with the penumbra catheter. So we continued to give a catheter-guided thrombolysis at 0.5 mg per hour of tenecteplase, and the sheath was removed at the bedside in the ICU using a Perclose Proglide. He was weaned off oxygen and discharged on the 7th day, basically to minimize any interaction. We didn't do any recheck angio in this patient, and he was given Eliquis for 3 months. So as you can see, the panel on the right shows the CT angiogram at presentation showing thrombus in the left iliac and thrombotic occlusion below the knee on the left side. Whereas the follow-up CT angiogram after 1 month shows complete clearance of thrombus in iliac as well as the good three-vessel runoff. This patient has been, he's recently come back for a 6-month follow-up. He's completely restored. There is no deficit. He did not lose any limb as well. So essentially, the questions to ask is, why do people generally develop arterial thrombosis? This is a common slide all of us learned, the Virchow's triad, wherein there is a triad of stasis, vessel wall injury, and hypercoagulability. So in patients with severe COVID, all three are met. They have endothelial injury, they have stasis, and hypercoagulable state. So this was a ICU study which showed that all patients with COVID have increased viscosity, and a very common pathology is fibrinolysis shutdown. So it is something like a DVT. So going back to the arterial thrombosis, almost 9% of patients had MI from registries in New York. So this just to say that despite intervention, there is a significant amount of mortality among patients with COVID limb ischemia. So both our patients fell under class stage 2B of limb ischemia. So ideally, surgical management would have been the management of choice, but going with other consideration, we went ahead with mechanical thrombectomies. So I'd like to conclude by saying that COVID causes varied spectrum of complication, and catheter-guided intervention is safe. And adjuvant thrombolytic therapy improves the chance of success. And more importantly, adequate precautions with necessary PPE to be taken for all procedures and cath lab, irrespective of COVID status of the patient. Thank you.
Thank you, Dr. Varsha. So right. Now, I'm sure this problem was faced by many other people, that patients had an ischemia, either myocardial or a limb, and they were not admitted because of their COVID status. So what would be the timeline? You believe that acute COVID infection or post-COVID infection is more likely to cause this thrombotic state?
So we've had a very varied spectrum of patients presenting. I think we had a total of 7 patients who came with COVID COVID and limb ischemia. So both these cases were in the first wave of COVID. So one of them had the symptoms almost 12 days into COVID illness, and the second person was a presenting symptom. He presented with just 4 days history of pain in the leg, and he incidentally had features of COVID on his CT, and he was refused admission.
And
most of the subsequent,
I'm sure the D dimer and sort of CRP would have been quite high.
Yeah, extremely high.
Yeah.
And subsequently, in the second wave also, we've had quite a few mix of patients. Like we've had patients who presented with a limb ischemia versus patients who were in the hospital for a month. I mean, not a month, a week or two, and then had developed limb ischemia in the hospital.
The issue here was that the patient was already on heparin and then developed it. So now that is something very scary, because we feel that once the patient is on therapeutic doses of heparin, that shouldn't occur. Did you place them on NOAC therapy later on?
Yeah, so most of our patients we've given 3 months of NOAC subsequent to the procedure.
Yeah.
And like you said, that the case 2 that I presented, he had a complete restoration of blood flow. He's not lost even a digit. He's gone back to work, doing extremely fine.
So, with your experience of this Penumbra device, you think that number one, it is suited for a relatively fresh thrombus, and what will be the other indications where you can think of this?
Like pulmonary embolism is another good indication to consider penumbra. So of course there are mechanical thrombectomy options like angiojet, etc. available in India. Just that I found penumbra is very easy to use. I mean, as you saw, it's just connect and play. In fact, subsequently, I know the company people would not like me saying it. I had just used regular GR catheter, any end-hole catheter, and connected to the penumbra engine, and it worked just fine. So you just need a good end-hole catheter which does not collapse to the pressure, and just use it. So minimize the cost as well.
Okay, well done. Any other comments from our panelist friends?
This is something
Varsha needs a real congratulations and very good approach, because I was there. And a person who is feeling almost going to lose the limb, and we did some innovative and very novel techniques, because it was done first time in our cath lab with the penumbra. And he did so well with the first time using penumbra and taking out. We have seen a big, just like an endarterectomy, the long, big chunk of thrombus coming out. And that was for me also, it was a first time experience. Looking at the penumbra in the peripheral arteries and taking out the entire chunk of this thing. He needs a good congratulation and good efforts. And I think all the new techniques are done by Dr. Varsha, and he is a very good, in fact, doctor for our cath lab interventionist. And
thank you for the kind words.